Hello students, this is Dr. McQueen Mendonca from the Department of Orthodontics, A.B. Shetty Memorial Institute of Dental Sciences. Continuing with the topic of removable orthodontic appliances, this is another segment on New Learn as part of the NIT deemed to be university online videos. We continue with the active components of a removable orthodontic appliance. As I mentioned, there is a acronym which we use as springs, bows, screws and elastics, the active components of removable orthodontic appliances. We will be seeing elastics and screws as part of removable orthodontic appliances. Now, the elastics which are used are more commonly used with fixed orthodontic appliances. They are seldom used with the removable orthodontic appliances. The elastics, if they are used with the removable appliance, there is some sort of a fixed component. Not very often by itself are elastics used. In comparison to a removable and fixed orthodontic appliance, the use of elastics in removable orthodontic appliances is not very common. Elastics, as I mentioned just now, they are seldom used in removable appliances. They may be used for movement of single teeth or groups of teeth and for intermaxillary traction. It resembles very similar to a rubber band and it's made of latex rubber. They are available in various diameters and the force applied depends on their diameter. They are color coded for easy identification. The first use of intermaxillary elastic bands was first described by Jackson in 1904. We have elastics we have intraoral elastics, we have extraoral elastics. Their application was greatly enhanced by introduction of the modified arrowhead clasps and the modifications of the Adams clasp. Intermaxillary elastics with removable plates can be used for the treatment of class 2 and class 3 malocclusions. Now we see these the aligners which cause movements of teeth. They are removable appliances and through various attachments they can be used for movements in a class 2 or a class 3 malocclusion. The disadvantages with the elastics being used with the removable orthodontic appliance are they slip gingivally and cause trauma, the risk of the arch form getting flat, and the continuous immersion in saliva causes a rapid force decay of the elastic. The uses of elastics would be for movement of single teeth and groups of teeth, for intermaxillary traction. Now this is an article which was in 1996, molar intrusion which was being done with a removable appliance. Just make a note of the article. We see the pictures used in the pictures, the way the elastics have been used for the molar intrusion with a removable appliance using elastics. Now we come to the second part of this topic, that is the screws. I mentioned springs, bows, screws and elastics. Now orthodontic screws which are used for expansion, they can be used as part of removable appliances and fixed appliances. So here we'll be talking of screws as part of removable orthodontic appliances. Screws in a removable orthodontic appliance cause slow maxillary expansion, whereas screws as part of fixed orthodontic appliances cause a rapid expansion. The orthodontic screw is an active component of a removable appliance that together with the acrylic plates can affect the teeth and alveolar process. Now in general with the removable orthodontic appliance, Anchorage, this is a separate topic. Just like to add a note here, anchorage comes by selective trimming of the base plate. Make a note of this. Anchorage in a removable orthodontic appliance comes by selective trimming of the base plate. Screws were first introduced by Schwartz. The features of screws are they have adequate amount of expansion, they have good enough stability and minimum bulk. Now this we see that they are used for removing individual teeth or groups of teeth. And we have the skeletal expansion screw and the dental expansion screw. Coming to the types of screws, we have screws used for maxillary expansion, for mandibular expansion, bilateral expansion, sectional expansion, radial expansion, and expansion in 3 directions. The screw consists of a central body which is generally divided into 2 parts. The central boss portion is drilled with 4 holes which are equidistant so that the screw can be opened with the help of a key by a quarter turn each time. This is known as the pitch of the screw. The guide pins can be single, double or U-shaped. Guide pins help in stabilizing the appliance. Precise parallel movement prevents the end plate from rotating for accidental recoil. Advantages of a removable appliance. There are many types of tooth movement possible. You can move individual teeth, you can move groups of teeth, activation with physiological limits, and there is less hyalinization. In biomechanics of tooth movement, or the basics of tooth movement, you would have read about what is undermining resorption. So yes, there is less hyalinization. Activation is precisely controlled and simple, and applies large intermittent force which decreases as the teeth moves. The disadvantages of a orthodontic screw in a removable appliance are they are bulky, expensive, turns back recoil under load, and yes, they require patient cooperation. The patient does not wear the appliance, there is no effective tooth movement. These are the special purpose screws, the skeleton type of screws available in various sizes, broader for maxillary and narrower for mandibular. For movement of a section of plate in case of limited space. Now we see in this picture that we can move the teeth depending on what type of tooth movement is needed in various directions, either in a mesodistal direction, in a sagittal plane, or in a transverse plane. For extensive distal movement up to 8 mm, designed by Weiss. This is the Bertoni screw for expansion in 3 directions. Now we see the proper placement of the screw here. The screw should not be placed as you see on the left hand side of the screen. This is the way the screw is placed properly. The horizontal plane of the screw is placed parallel to the plane of the palate. Now this is the wrong way. If you notice the way the screw is placed, it is not placed parallel to the plane of the palate. Now this is the right way it is placed. This is when we view it in cross section. Fine type of expansion screw or a pivot screw used for anterior segment of the maxillary arch requires more expansion than the posterior segment. Posterior segment remains unchanged through a built-in rotation. Anterior expansion of the arches to correct maxillary anterior crossbite. This is another type of screw. Then we have the transverse expansion of the arches. In case of constructive maxillary arch, it can be used even in a growing patient in the mixed dentition phase. Active plate is split in the midline, will expand the arch almost totally by tipping the posterior teeth buccally and not by opening the mid-palatal suture. This is generally obtained by opening the mid-palatal suture fixed screw, otherwise known as the high rack screw. That is a separate topic, so we won't talk about the high rack screw or the other types of rapid expansion. An orthodontic screw, a removable orthodontic appliance screw, causes slow expansion of the arches. Here we see simultaneous anterior and posterior arch expansion. It is possible to expand particularly in the maxillary arch by dividing the base plate into 3 rather than 2 segments. Here we see a screw placed for movement in the transverse plane or in the sagittal plane. Now the activation, the screw is turned 90 degrees, will drive the parts of the plate apart by 0.2 mm. Narrows periodontal membrane by 0.1 mm on each side. This is the ideal orthodontic condition for transformation of bone. Uses are the base plate divided into sections driven apart by 1 or more screws. There is split along the midline. Bilateral crossbite and minor crowding of incisors can be corrected. Split into a larger and a smaller part. Now we see this picture here. When we need posterior movement of the teeth, the way the screw is placed. As I mentioned earlier, Anchorage comes from selective trimming of the base plate. So base plate is trimmed in the regions where we don't need anchorage, and it is trimmed and extended to the neck of the teeth, where we need the movement of the teeth. This is a picture where we see again how the screw is placed parallel to the palatal plane. Now, just to give you an idea how the screws work, pre-treatment, you notice that there is a crossbite in the anterior segment. These are all pictures from the department itself. This is a crossbite. Post-treatment, we will see the pictures. A screw is placed in the sagittal plane to cause the movement of the incisors, labial movement of the incisors. The screw is activated. Then you see post-treatment, the crossbite is corrected. Now this is in a mixed dentition phase. You notice that there are the milk teeth or the deciduous teeth as well. It's a mixed dentition phase. Complete correction of the crossbite. So corrections like this help the patient even psychologically, especially when there is a crossbite in the anterior region. Lingually locked and crowded upper central incisors tipped forward using springs after space provided by moderate expansion. Now we see this picture. There is a spring being used to correct the teeth to correct the crossbite in the anterior segment, and also posterior expansion. Here we see the bite plate, posterior bite plate. This causes the expansion. Various springs used along with the expansion screw. Expansion and reduction of overjet. Here you can see that there is an expansion and reduction of the overjet. The labial bow causes the reduction of overjet and expansion of the posterior segment. Y plates for alignment of crowded canines by sagittal and lateral expansion. Now this we see the screws placed, one for the anterior movement of the incisors and for posterior expansion as well. This again requires patient cooperation. Thank you.